Good evening, everyone, and a very, very warm welcome to everyone who's joining us this evening. I'm Dr. Deepika. I'm working as a cataract and oculoplasty surgeon at Hyderabad Main Hospital for Dr. Agarwals. Thank you to the Education Committee and Dr. Preethi specifically for inviting me to moderate this session. Extremely interesting topic today, orbital fractures and overview, a topic that sits at the intersection of trauma, aesthetics, and functional rehabilitation. As eye doctors, all of us are acutely aware of the need of balancing timely intervention along with evolving technology for best possible patient outcome, especially in trauma cases. So let's dive into the world of orbital fractures. It's my pleasure to invite Dr. Balasubramaniam sir as the esteemed speaker for today. Dr. Bala is working with us as a senior consultant in oculoplasty and orbit services at Chennai Main Hospital for Dr. Agarwals. He was trained at the world-renowned RP Center AIMS, New Delhi. He brings with him a vast clinical experience of more than 25 years now, managing patients with complex lid and orbital disorders. He is especially interested in management of complex conditions of eyelids and orbit as well, and providing best possible cosmetic rehabilitation after trauma cases and also after tumor excision. Dr. Bala,
Yeah. Thank
over
you.
to you, sir.
Yeah, thank you, Dr. Deepika, for the
Thank
kind
you, sir.
introduction. Yeah, thank you. Yeah, anyway, thanks to the clinical board and Dr. Preeti, yeah, for the opportunity. The topic is orbital fractures and overview. So just wanted to give a overview of the topic so that it's like more like a basic thing so that all general ophthalmologist residents can find it useful. Yeah, so before diving deep into the topic, so we'll revisit the orbital anatomy so that it will help us to understand the topic better. So the orbit is a pyramidal structure, base at the orbital aperture and the apex towards supromedial at the optic foramen. So the medial wall, I'll like to start with the medial wall. So medial wall is formed by the frontal process of the maxilla, the posteriorly then lacrimal bone, then the orbital plate of ethmoid, which is in the center, and the body of the sphenoid. The floor is formed medially by the maxilla, laterally by the zygoma, and the palatine bone posteriorly. So this palatine bone is important because that is the posterior ledge on which we place our, although it is a very small bone, so that is the posterior ledge on which we place our implants during orbital floor fracture repair. And the lateral wall is formed by the zygomatic process of the frontal bone, the zygoma, and the greater wing of the sphenoid. So the roof is formed by the orbital plate of the frontal bone and the lesser wing of the sphenoid. So the structures within the annulus of Zinn is the third nerve, the superior and the inferior division, and the sixth nerve. The structures outside the muscle cone, that is the lacrimal nerve, frontal nerve, and the trochlear nerve. And so these are the main structures, although inferior orbital fissure also has some structures. Sometimes during fracture repair, if the fracture is very severe, we might have to sacrifice the structures in the inferior orbital fissure. And the infraorbital nerve comes into the orbit through the inferior orbital fissure. And that is the location, the bone, the infraorbital canal is one of the commonest sites where weakest sites in which the orbital blowout fracture, floor fracture occurs normally. So the types of fracture, so one is the blowout fracture, other is the blow-in fracture. So blowout fracture is in which the orbital walls move out of the orbit, and blow-in fracture is in which the bone, like in the roof, normally when there is a roof fracture, the bone comes into the orbit. So it is a blow-in fracture. So both blowout fracture and blow-in fracture can be present in the same patient, and normally a blow-in fracture causes proptosis. So blowout fracture of the orbit is basically defined as a traumatic deformity of the orbital floor or the medial wall, typically from an impact of a blunt object larger than the orbital fissure aperture. So basically anything larger than 5 centimeter which occludes the orbital aperture causes a blowout fracture, and the bone is displaced away from the orbit. So pure blowout fracture is one in which the orbital rim is not involved, and an impure blowout fracture is in which the orbital rim is involved. So blowout fracture can be categorized broadly as a open door fracture or a trapdoor fracture. Open door is one which normally occurs in adults. It's a large fracture and the contents are displaced and the bone is comminuted. In a trapdoor fracture, the bone is generally not much minimally displaced and the fracture is generally linear and hinged. So you can see the hinge in this trapdoor fracture and the inferior rectus which is entrapped. So the etiology, normally road traffic accidents are the common cause of orbital fractures, and assault in which punch to the eye, and or in sports activities like boxing or fall also can cause a orbital fracture. So how does a orbital fracture occur? So basically, two theories are proposed. One is a hydraulic mechanism theory, an object which is larger than the orbital aperture. When it strikes the orbital aperture, basically it causes occlusion of the orbital aperture and it increases the orbital pressure and leading to a blowout fracture of the posteromedial orbital wall, which is the thinnest portion of the orbit. And the other is a buckling mechanism theory in which striking force causes a deformation instead of striking the orbital aperture, injury to the directly striking the rim causes a deformation force which is transmitted to the orbital floor causing a blowout fracture. So the facial buttresses are the important support framework for the face. So these carry all the stresses of the so the superior orbital rim or the frontal bar is a horizontal support. The other is the inferior orbital rim. Third is the hard palate or the upper alveolar ridge. And the fourth is the body of the mandible. And the vertical buttresses are the nasomaxillary, then the zygomatic-maxillary, and the pterygomaxillary, which is normally little posterior, and the vertical mandible or the ramus of the mandible. So the initial evaluation is usually done after we secure the vitals. So basically the ABC, which we all know, airway, breathing, circulation. After all this is secured, only then we proceed with the evaluation. So visual acuity, the pupils, whether there is any pupil IPD and the pupillary reaction, and the extraocular movements. Extraocular movements are only elicited if there is no any rupture of the globe and whether if there is no pain on movements. And we also look for any diplopia. And intraocular pressure is also important. And IOP may increase when the pressure is measured in the away from the direction of the entrapment. If the medial rectus is entrapped, then when the patient looks in abduction, then the pressure may increase. Or if an inferior rectus is trapped, when the patient looks up, then the pressure may rise. So that is also one of the signs that there may be an entrapment. And the external examination or the periorbital examination, we see for if there is any ecchymosis, any lacerations, and we palpate from top down. So we initially examine the superior rim, then we come laterally, and then we come down. So, and we look for if there is any crepitus or anything. And slit lamp examination, we see the cornea, the anterior chamber, if there any laceration, and the anterior chamber, is there any inflammation or any angle recession, and the lens. And we also check for color vision to see if there is any optic nerve injury. And we also see the globe position, whether there is any inophthalmos, whether there is any hypoglobus. And we can use a Hertel's exophthalmometer. And if the lateral wall is injured, then we can use a Nagel's exophthalmometer, which rests on both the superior and the inferior periorbital area. And visual field examination is also must. And a dilated fundus examination is important. Hess charting used to be done previously, but now we rarely do it. So when to suspect there could be a orbital fracture? So going by the history, so when there is a history of trauma with a larger object than the orbital aperture, like a ball, a fist, and if there is any history of epistaxis, mainly a unilateral epistaxis, or there is a sudden increase in the swelling after blowing the nose. So that could give an idea that there may be a fracture. So coming to the examination. So normally ecchymosis and edema of the lids. So when there is ecchymosis, edema, so maybe the force was severe. And any diplopia with limitation of motility can be due to either orbital edema, hemorrhage, or damage to the muscles or the innervation, and not only because of any entrapment. So the second picture shows white-eyed fracture, white-eyed blowout fracture because of a trapdoor fracture. So there are no obvious signs of orbital fracture except for the limitation motility. These patients can have bradycardia and maybe nausea, vomiting, vagal symptoms because of the entrapment of the muscle. And there could be in ophthalmos hypoglobus, and force duction test can suggest if there is any entrapment. So, but rarely we do it in the outpatient because of the patient cooperation. Generally, we do it intraoperatively when the patient is under general anesthesia. So, in examination, presence of hypoesthesia, basically numbness or paresthesia of the cheek, nasal ala, the upper lip, and upper teeth, basically the distribution areas of the infraorbital nerve, and presence of bradycardia, the ocular cardiac reflex, along with nausea and vomiting, can be due to the muscle entrapment in trapdoor fractures. So other injuries associated with orbital fractures are globe rupture, retrobulbar hemorrhage, any antichamber, hyphema, angle recession, subluxation or dislocation of lens, any glaucoma, vitreous hemorrhage, or retinal detachment. So what investigations will we do? So X-rays, there is minimal role in diagnosis and treatment as of now. So generally we don't do X-rays, and CT scans is the investigation of choice. So minimum 2 mm cuts. We have to get all the axial, coronal, and sagittal cuts. So all three. And if we suspect any optic neuropathy, then we go for 0.5 mm cuts through the optic canal to see if there is any optic canal fracture or any bony impingement from a fracture. So the coronal and sagittal cuts are important for the floor and the roof fractures, and axial cuts are important for medial wall, lateral wall, and optic canal fractures. MRI is a useful adjunct, and that is mainly done when soft tissue injuries are there, and we suspect any muscle entrapment and optic nerve damage. And in case of roof fractures, to see if there is any herniation, brain herniation into the orbit in case of blow-in fracture. So CT scan, we need all the three planes, axial, coronal, and sagittal. And this picture shows a typical teardrop sign in case of a blowout fracture of the floor. So how do we manage? So initial management is we apply ice packs to the affected area, and we ask the head end to be elevated. We can prescribe nasal decongestants, and broad spectrum antibiotics like Augmentin. And oral steroids is normally prescribed for about 7 days. And the main thing is we ask the person not to blow the nose. So because that can cause emphysema and can lead to a orbital compartment syndrome. So indications for repair. So when do we repair all fractures? So these are the indications. So whenever the patient presents to us immediately after the injury, if enough thalmos is there or any hypoglobus is there, that means in spite of all the edema and all this one, so the patient has enough thalmos. So that means the enough thalmos is severe. Or while following up the patient for up to 2 weeks, if the ophthalmos is more than 2 mm, or if the patient is cosmetically finding it unacceptable for him, then we go ahead with the repair. Or if there is any severe restriction of eye movements with the CT or MRI evidence of muscle or soft tissue entrapment. Or in case of white eye blowout fracture in a child or young adult with severe motility restriction, along with nausea, vomiting, and bradycardia. Or if the defects of the orbital floor are more than 50%. or in case of non-resolving and persistent diplopia for more than 2 weeks, then we go and repair. So the contraindications when we don't repair, when there is any globe rupture or any hyphema or subluxation dislocation of the lens or retinal tears, we give importance to that. And so the fracture repair takes a backseat. Or if case of that being the only seeing eye, so then also we don't repair the fracture. So timing of the repair. So normally in case of trapdoor fracture, we repair it within 48 to 72 hours because of the oculocardiac reflex, and persistent entrapment can lead to ischemia and necrosis of the muscle. Or in case of open door fractures, we can wait for about 7 to 14 days for the repair. So how do we approach the fracture site? There can be a transcutaneous approach or transconjunctival or transantral or a coronal approach. So lid crease incision and the subrow incision can give us access to the superior orbital rim and the roof. And the lid crease, we can also access the frontozygomatic suture on the lateral wall. And inferiorly for the floor, we can approach to the subciliary incision or the lower lid subtarsal incision or the orbital margin. Although we don't do the orbital margin incision, and subciliary also in selected cases only when there is severe edema and which precludes us from doing a transconjunctival incision. So transconjunctival approach is the one which we normally prefer because there is no visible scar and the chances of lid retraction and ectropion are minimized with the transconjunctival approach. Transcanalicular or a retrocanalicular incision is used for the accessing the medial wall. So transantral endoscopic assisted approach can be used for the floor, and the coronal approach gives us access to the upper and the middle third of the face, including the orbit. So basically used mainly in case of roof fractures. So what are the materials which we can use? So the implant material depends upon the age of the patient, the size of the defect, and whether any support is there for the implant to sit, and presence of any comminution. Because if there is any comminution, then we may have to go for a rigid implant. So autografts, bone and cartilage. So bone and cartilage can be used. Bone from the calvarium and the iliac crest and all can be used. But the only thing is that it has to be carved. Although the floor is normally not a flat surface, it is S-shaped. Initially, it is starting is yes, and it deeps down, and then again the posterior is little higher. So it is S-shaped. So a bone graft may not be suitable for that, and the chances of bone resorption is also there. So the rigid support later on is doubtful. So cartilage can also be used, septal cartilage or auricular cartilage, but that generally is solely suitable for very small defects. So alloplastic materials are the ones which are commonly used. So non-absorbable, titanium mesh, porous polyethylene, PTFE, nylon foil, or silicone sheet. So titanium mesh and porous polyethylene are the common implants which we use. So silicone sheet is normally not used because it doesn't provide any rigid support, and it generally bows, and there is a pseudo capsule formation around the silicone sheet. And absorbable implants are gaining popularity because it prevents the long-term complications of implant. And mainly these are suitable for children, because children less than 5 years of age, if we put in a rigid implant with screws, then as the skeleton face and bone grows, then there can be displacement of the screws. So absorbable implant mainly of polycapronolactone, polylactide and polyglycolic acid polymer implants are available, which can be used, but they have limited role, mainly if only when there is support, 4-point support is there and the fracture size is smaller. So porous polyethylene is one of the common implants materials which we use. So advantages are easy availability, easy contouring, The edges are smooth and it allows tissue ingrowth. The main disadvantage is it is not radio opaque. So when we do a post-operative scan, it is not visible. So if there is any residual in ophthalmos, so we won't know so whether the implant is correctly placed. So that is the main disadvantage. And lack of rigidity. So in larger fractures or in commuted fractures, it won't be appropriate. And if we use a thicker implant, then the risk of dystopia is there. And it also allows less drainage, although it has pores, so it allows less drainage from the orbit than titanium. So basically, post-operative orbital compartment syndrome chances are there, although it is rare. So titanium meshes are one of the most commonly used implant material. Basically, they can be used for large orbital defects. Basically, this is a pre-bent titanium plate because the floor is S-shaped. So we get this pre-contoured or pre-bent implant so that we don't have to do it ourselves. So it makes us easy because the operating time is also less. So advantages of this titanium mesh is it's more stable, it is biocompatible, and ease of contouring, and it is radio opaque so that when we do post-operative scans, we know the position of the implant. And it also has spaces, so any blood which collects drains into the maxillary sinus. And no donor site, like in case of bone or cartilage graft. And tissue ingrowth can occur into the implant. So relative disadvantage, basically the cost and the possible sharp edges if it's not properly trimmed. So we have a composite implant where porous polyethylene is combined with titanium. Basically, this is more rigid than a porous polyethylene, but it allows less drainage from the orbit. So resorbable materials are polylactide, polygalactin, polydioxanone, and polycaproelectron sheets. So basically, it's mainly useful in smaller fractures with stable borders. Advantages are biocompatible, pliable, and can be contoured to the defect, and they're resorbable. So thereby avoiding the long-term complications of the implants. So disadvantages are basically the cost and the concern for long-term stability. Although generally they stay for about 18 to 24 months, by which time they get hydrolyzed and absorbed. And they promote new bone formation, and they are not also radio opaque. So we won't be able to see them on post-op CT. So this is a short video of a medial wall fracture repair. So this is the transcanalicular incision being performed. So we enter the medial space at the posterior to the posterior lacrimal crest. And so we see that the muscle and the soft tissue is entrapped. So to release that, we enlarge the bone surrounding the entrapment, and we measure the size of the defect. And this is a porous polyethylene sheet being put, and we stick it with the glue, cyanoacrylate glue, so that for the initial 3 to 4 weeks, the support is there. But finally, there is ingrowth and the implant becomes stable. So what is the post-operative care? So basically, advise head and elevation, and we check the pupils, the visual acuity, or any proptosis. Initially, for the first 24 hours, we monitor more frequently, and we apply cold packs for 2 to 3 days, and we advise oral steroids and oral antibiotics, and we advise not blowing the nose. And if the patient has any sneezing or anything, so we ask the patient not to close the nose or mouth and then sneeze. If there is no improvement in motility post surgery, and we can do a repeat CT to find the position of the implant. And in these cases, radio opaque implants like titanium are advantageous. So what are the complications? Intraoperative complications can be globe and optic nerve injury, injury to the infraorbital nerve in floor fracture repair, or inadequate reduction of the prolapsed tissue, and or any orbital hemorrhage leading to a compartment syndrome, orbital compartment syndrome. So, what are the post-operative complications? Loss of vision, persistent or worsening of diplopia, globe malposition, persistent in ophthalmos or hypoglobus or hyperglobus, infection in the form of orbital cellulitis, infraorbital hyposthesia, anesthesia, or in case of flow repair, and lid malpositions like lower lid retraction, ectropion or entropion. Entropion is more common in transconjunctival, although it's relatively rare compared to a lid retraction and ectropion in case of a subciliary or subtarsal. And implant infection, migration or extrusion is also known. Or there can be epistaxis or CSF leak in case of medial wall repairs where we cross the frontoethmoid suture. So this is a patient with orbital floor fracture. So you can see that there are no apparent signs of trauma. So unless because this is a 17-year-old boy, so and they may not give the history because they may hide the history of trauma. So in these patients, so basically extraocular movement examination will give us the clue regarding the diagnosis. So basically in floor fracture, so you can see the hinged portion of the bone, and you can see in the first picture you can see the inferior rectus lying in the maxillary sinus. So this is a 4-year post-op. So that patient I did just before first lockdown. So the patient again came after 4 years. So this is the picture. So now he doesn't have any diplopia and the movements are full now. So again stressing the importance of adequate release of the entrapped contents and placing the implant over the posterior ledge. So this is another patient with a medial wall fracture. So 15-year-old boy sustaining injury to the side of in the periorbital area. So you can see that the adduction is restricted and in the left eye, and there is a minimal abduction restriction also, and you can see that the patient has a significant face turn. So this is a medial wall fracture, trapdoor fracture with the medial rectus entrap. So this is the post-op. So you can see that the adduction has improved and the abduction is also improved, and you can see that there is no face turn now. So other fractures associated with the blowout fracture are zygomatico-maxillary complex fractures. Basically, it is a tetrapod fracture where the zygoma, where it is anastomosed with the other bones. So, basically, a fracture of the fracture involving the frontozygomatic suture, the inferior orbital rim, the zygomatic arch, and the lateral wall of the maxillary sinus. So, this is a patient who had a ZMC fracture and along with the ectropion, he had a thysis bulbi. So, injury sustained during violence. So generally ZMC fractures cause closed displacement, lateral canthal dystropia, diplopia, trismus because the zygoma moves down and obstructs the condylar process of the mandible, so causing trismus, and it also leads to a cosmetic deformity. So open reduction and rigid plate fixation if there is a significant displacement. So you can see the pre-op his 3D CT and his final picture. First we did the orbital floor reconstruction plus the zygoma fixation, followed by lower lid scar release along with the skin graft and a enucleation with the ball implant, and followed 6 weeks later by customized processes. So this is his appearance after all the both bony and soft tissue repair. So another common fractures is a naso-orbital ethmoid fractures. This is the most difficult and demanding fracture to treat. So in this, it usually occurs due to face striking a solid surface. So in this, the basically the medial wall is involved. The frontal process of the maxilla, the lacrimal bone, and the ethmoid are involved. Basically, it presents with a depressed nasal bridge and a traumatic telecanthus. So complications generally cerebral damage, eye damage, epistaxis, orbital hematomas, and CSF rhinorias can be there, and also damage to the lacrimal and a lateral displacement of the medial canthus causing telecanthus, and there can be associated fractures of medial wall and the floor. So anoid fractures basically we treat by a microplate fixation, and transnasal wiring is rarely done nowadays. So after in patients with the NOE fractures, there can be NLD obstruction. So you can see there is telecanthus in the photo, and this is a CT dacrocystogram showing no in the above picture. There is a flow of that is the NLD with the dye going into the nose in the right side, whereas in the left side there is a block, so there is no flow of dye into the NLD. So in cases of this NOE fractures, after this plate fixation, also that can also be one of the causes of nasolacrimal duct obstruction. Either can be it could be due to the fracture of the nasolacrimal duct wall itself, or it can be due to the implants which we place. So you can see the third picture in which there is a screw close to the NLD. So basically, CT dacrocystogram is a useful tool in these cases. So it gives an idea as to the location of the sac also in relation to the bone. So when we do a DCR, so we know like, okay, the sac is this far away from the bone. And basically, if it is a minimal fracture, so not much scar tissue, so then we can do a plain DCR. But generally, a DCR along with intubation and along with the mitomycin C increases the chance of success. So mitomycin C in the concentration of 0.2 to 0.4 milligram per ml for 3 to 4 minutes will be helpful to prevent further scarring and occlusion of the osteum. So orbital roof fractures, basically it happens in blunt trauma or in projectiles which injure the roof. And young children are more prone to roof fractures because in those the ratio of the cranial wall to the mid face is greater. So and these are generally and can occur with relatively minor trauma also, and basically they are non-displaced and linear fracture, and they can have a delayed ecchymosis of upper lid after even a minor trauma. So complications of a roof fracture are basically intracranial injuries, CSF rhinorrhea, pneumocephalus, pulsatile proptosis, subperiosteal hematoma, ptosis, and extraocular muscle imbalance. So most of the fractures require no repair, and generally even in and the treatment is generally along with a multidisciplinary team involving neurosurgeons and ENT. And orbital apex fractures usually occur in association with other fractures of the face, orbit, or the skull. So optic canal, superior orbital fissure, and structures that pass through them may be involved. So complications are a traumatic optic neuropathy, a CSF leak, and a keratoconus fistula. So orbital CT with the 0.5 millimeter to 1 millimeter cuts is required to look for any fracture in the sites and any bony compression of the optic nerve. So midfacial fractures. So Lefort classified them as Lefort 1, Lefort 2, and Lefort 3. So Lefort 1, there is no orbital involvement, and Lefort 2, it's a pyramidal configuration in which the nasal, lacrimal, and the maxillary bones and the basically the medial and orbital floor are involved. And Lefort 3, there is a craniofacial disjunction in which the facial skeleton is detached from the base of the skull, and they are only attached because of the soft tissue. So orbital floor, medial wall, and the lateral walls are involved. So along with the fractures, generally foreign bodies can also be there in the orbit, and so this is a metallic foreign body near the lateral wall. So not all foreign bodies need to be removed, and if there is a organic matter foreign body, then it has to be removed. So this is a patient who had a injury with the tree branch. So you can see that how many pieces we have removed, and it is a painstaking process of removal, and we have to remove all the pieces which are there, and it is difficult to diagnose on imaging also the wooden foreign body. Initially it gives appearance like that of air or fat, and so you, whatever foreign body, generally we don't go ahead with an MRI unless we know that it's not a metallic foreign body. Only CT is preferred first, and then if necessary we go ahead with an MRI. So this is a patient. This patient, the first photo is the pre-op, and the third photo is the post-op of skin grafting and further scar modulation with 5-fluorouracil also. So if there is any sinus which is there and it is non-healing, then you suspect that there could be a foreign body. So imaging and then removal of it only heals once the foreign body is removed. So along with orbital fractures, a blunt trauma can cause a orbital compartment syndrome. So it could be due to a orbital hemorrhage or a emphysema. So basically, it presents with the tight orbit with proptosis, decrease in vision, afferent pupillary defect, and restricted extraocular movements and elevated IOP. So this is a diagnosis. This is a clinical diagnosis and not a radiological diagnosis. So we don't go for an imaging first when we suspect that there is a orbital compartment syndrome. So we don't go for imaging, and we immediately do a lateral canthotomy and cantholysis. So it can be done in the bedside. So this is a short animation showing lateral canthotomy and cantholysis. If the orbital pressure is relieved in the inferior cantholysis itself, it is sufficient. Otherwise, we can do a superior canthotomy and cantholysis also. So this is a video showing inferior canthotomy and cantholysis. So we apply a hemostat, and then we do a inferior canthotomy and cantholysis. So basically, it is not the lower lid becomes loose, not in just one cut. We have to do multiple cuts to release the lower lid from its attachment, and we don't suture the incision immediately. So first we do the inferior canthotomy and cantholysis, and if there is no, and we wait, and if there is no improvement, then we go ahead and do a superior cantholysis also. So along with the orbital fracture, traumatic optic neuropathy is also quite common. So it can be because of any direct injury, like in case of a penetrating trauma or a bone fragment compressing the nerve, or a optic nerve avulsion, or it could be due to indirect injury in the form of a frontal blow or a rapid deceleration of the cranium. And high dose steroids are normally given, but that is contraindicated in cases of acute traumatic brain injury. But still, high dose steroids is still controversial, and so just with observation alone versus steroids, so the results are almost the same. And surgical decompression of the optic nerve is reserved for patients in which there is a presence of bony compression, or there is a optic nerve sheath hematoma, or a compressive retrobulbar hemorrhage. And we have to look for any features of keratoconus fistula in cases of history of trauma. So you can see that there is minimal congestion. So high index of suspicion is important. So when we do the investigation, so we do a MRI with MRI angiogram. Then the gold standard investigation is a digital subtraction angiogram. Then we can do a endovascular embolization in the form of coiling. So this was a challenging patient who presented to us with the history of injury to the left side of face. So he was an outstation patient, and the primary repair was done there itself in the form of he had a globe rupture also, so suturing of that, and his maxilla was he had some microplates in the maxilla. So this is his CT scan. You can see that the floor and all is communicated, and there is a the ZMC is not properly fixed. So it was a challenge because So he wanted a better cosmetic outcome. So to provide a good cosmetic outcome, we have to perfect normal or near normal to the opposite side. So we did and we have to undo what has been already done and then redo. So we did a 3D model for him and we did a virtual surgical planning. So this is the first image. You can see the three models. The first model is his present condition. So model according to the present. And the second model you can see that is by segmentation, and you can see after the actually this one is segmented and the ZMC is fixed in that. And the third is the mirror image of the right side. The left side has been made a mirror image from the right side, and that is the model. And you can see the second photo. So that is the guide which they provided after the ZMC is fixed. So that is because the inferior orbital rim was comminuted. So they gave us a guide. So you can see the holes. So where the screws to be placed. And the third is so basically the mirror image of the right side. So this is the intraoperative. You can see the first photograph showing the committed fracture of the floor rim. And this is the second picture shows the guide being used intraoperatively. And the third photograph shows the titanium floor implant plus microplate for the inferior rim. So this is his post-operative CT showing adequate placement of the implant and a volume correction. So this is his first we did the bony framework. So and after 3 months we did a lower lid skin graft plus enucleation. So the patient is awaiting a customized prosthesis. So you can see the first picture showing a superior sulcus deformity. The superior sulcus is deep, and you can see the volume correction in the superior sulcus in the second picture. So this is his pre-op when before we did the correction. So basically we had to remove all the microplates which were put earlier, and then we had to redo. So you can see the 3D reconstructed image after we have done. So you can see the floor implant in place and the frontozygomatic microplate and the inferior rim microplate in place. So that patient we did with the virtual surgical planning. So for a good outcome, so we had to use that. And even the other advances are image guided surgical navigation. Okay, or the other thing is a patient specific implant where we can do a reconstruction of complex defects and deformities. So normally the materials used are titanium or PEEK, which is polyether ether ketone. Basically, the advantages of patient-specific implant are minimal or no countering, reduced operative time, and the disadvantages are the cost or time required to obtain the implant. So advantages in computer-assisted design and computer-assisted manufacturing technology. So there is more timely and precise fabrication of the patient-specific implants. So finally, I conclude by saying that a high index of suspicion that there could be a orbital fracture and adequate primary repair involving all the walls, whatever fracture is there, if we adequately treat all of them, that will decrease the chances of residual inophthalmos and provide a adequate cosmetic and functional outcome. Yeah, thank you.
Thank you so much, sir. This is such a vast subject, and you've covered it beautifully in such short duration of time. Thank you. I think you've answered most of the questions already for
Yeah,
basics for sure. But I'll
yeah,
still get to the audience section and I'll quickly ask a few questions, sir.
yeah.
Somebody has asked, what is the mechanism of the fracture in a blow-in fracture?
So blow in is basically a direct injury, or so that is the thing, a direct injury to the superior rim. Okay.
Right, sir.
So,
Compression,
so
basically.
basically, yeah, direct injury.
Okay. Next question is, why is the surgical repair contraindicated in a patient who's one-eyed in the seeing eye?
Why it is contraindicated? As you all know that orbital fracture repair itself can have its own set of complications. Like when we do the surgery, there can be with the manipulation, there can be optic nerve injury or globe injury and all. So
Right.
okay, so that itself can and there can be chances of orbital hemorrhage or also
Not to
post-operative.
risk the vision of the patient,
Yeah,
basically. Next, sir, somebody has asked, Is titanium contraindicated for MRI,
No,
titanium
no,
implant?
no, it is not contraindicated.
And is it necessary to go for 3D CT in all cases?
3D CT
3D
only.
reconstruction?
3D reconstructed images are generally basically they do with the normal CT which we do itself. They give the 3D. There's nothing special in 3D. Only thing is that it will give us an idea like how the fracture is and topographic alignment. So
I
that
think
when
as long, yes, sir.
yeah.
As long
So
as we get all the basics right, all the scans, axial, coronal, and sagittal
yeah,
with 2
yeah,
cuts or 1.5 cuts, that's
yeah,
more
yeah,
than enough in
yeah.
most cases.
Yes,
Right,
yes.
sir. Dr. Reshvin from the Mauritius branch, he is asking, he has a case scenario for you. I'll just read it out, sir.
Yeah.
A case patient with significant orbital floor and medial wall fracture with significant enophthalmos after edema has resolved. For wall repair, would you prefer an absorbable mesh or metal plates and screws? And how would you account for the amount of orbital tissue loss or atrophy so that there is no resultant enophthalmos?
So he says that there is a significant fracture.
Yes,
That means
large
we cannot
fracture.
yeah, so we cannot use the
Exactly.
resorbable. So we have to go for rigid.
Rigid.
So after the fixation, generally, if there is any fat atrophy and all that, then after the this one, then maybe we can further augment it. If there is any ophthalmos, we can put in ophthalmos wedges or anything. So it depends. So after the
Augmentation,
yeah,
space augmentation,
yeah,
second
yeah.
procedure.
Volume augmentation can be done.
Right, sir. And similar on similar lines, would you treat if the patient has presented to you with a late onset enophthalmos? Patient has not presented to us in the acute phase directly after maybe a couple of years with the enophthalmos, sir. How would your approach be different then?
So that's what, like late in ophthalmos, basically where there is contraction and that pulls the contraction at the fracture site and it pulls the
Yes,
eye
sir.
or in. So we again go in for release of all the, although that will be a challenge,
Very
surgical
difficult.
challenge.
Yes,
Yeah,
sir.
that will be a surgical challenge. So we
And
can
also because of the fat atrophy.
yeah, yeah. So we'll have to see. It may not be possible in one sitting. So we may have to do multiple sittings also.
For a particular patient, although you have covered implants in a lot of detail, but any single or one or two pointers to the type of implant that you want to go for in any particular case.
So for children, generally
Titanium versus mesh. Yes.
titanium versus poly
Medpore, sir.
4.
Yes, sir.
So so that's what titanium only if there is any loss of like the whole floor is gone. Okay. So and there is no support for a Medpore. So
Yes,
in
sir.
that case, go for a titanium. So otherwise,
Larger
Medpore.
fractures.
So Medpore you'll have to have this 4 point support. Okay. Only
Yes,
then
sir.
we'll have to go in with the Medpore or a resorbable implants. Otherwise,
Right, sir.
titanium.
One more question. What
Yeah.
about persistent diplopia even after fracture repair? Let's say more than 2 or 3 weeks. How do you approach that? And when do you involve a strabismologist?
I normally like we get a splint opinion even before surgery itself. So they know, so they do all the measurements and so they know that how it is progressing. Okay. So I generally involve them before itself, preoperatively
Right,
itself.
sir. In all cases, sir?
Yeah, generally
That's
I
great.
saw that. So like after surgery, so there is no surprise. So they are also like aware. So
Right, sir.
not that they have to intervene. Okay.
Right, sir.
So basically, sometimes it may take even up to months, maybe 6 months also. So generally, wait for at least 6 months also. Okay.
Before a
So
squint surgery is
yeah,
required.
yeah, before
Right,
any
sir.
surgical intervention is done.
Exactly. Right, sir. Sir, in case, like I was personally also discussing this with you earlier, you've already covered traumatic NLDO in detail. So, for
Yeah.
example, if this surgery has been done somewhere else by a maxillofacial surgeon and then referred to you with a late onset traumatic NLDO, how do
Yeah.
you approach the case, sir, then? Because if the mini plate or something or the
Yeah.
implant is impinging in that area.
So, like I tell the patient that either they can go ahead and ask the maxillofacial person who has done it either to remove it, or I tell them before the surgery that I may have, if it is coming in the way of the ostium which I am going to make, then I may have to cut that implant in that area. So
Mm,
that's
right,
what I
sir.
tell them. preoperatively.
Does that have any repercussions, like clinically significant consequences, if you remove that particular mini plate?
So I don't think so. I don't. By that time, the fracture would have healed.
Would have healed. Correct, correct.
Yeah.
Thank you, sir. This was a pretty in-depth discussion, I think, and I hope it was extremely useful for general ophthalmologists as well. And thank you so much. This was a very good presentation, sir.
Yeah. Thank you so much.